Yeah.
So how many of you are going to be flying? How many of you are going to be flying for Thanksgiving?
No, thank you.
Is anybody going to fly for Thanksgiving or are you going to be at home? At home.
We're driving
Yeah, you're driving. That's probably smart.
out east to Philly, so we'll see what the weather does. Tends to be bad. Yeah, I think northern Indiana and then kind of out through the east. Exactly where you're jumping. That's what I'm saying. Sorry, emails and students. That too.
Okay, they gave me the gavel again. So we will officially call to order the Governor's Public Health Commission for November 18th, 2021. So welcome, everyone, and thank you all for your time and commitment. I know many of you have been spending time talking with staff and answering a lot of questions, and hopefully you're talking to folks back in your home areas and your associates and so forth about the work of the commission. Shane, do we have a quorum?
Let me do a roll call. I see a couple people missing and I just want to make sure I don't miss anyone. Dr. Box,
Here.
Dr. Monroe,
Here?
Senator Kenley,
Here.
Dr. Maxey,
Here.
Mr. Ellison, absent, Mr. Tabor, absent, Dr. Veal,
Here.
Ms. Irwin,
Here.
Ms. Waldron,
Here.
Dr. Halverson. Here. Dr. Kane. Absent. Dr. Welsh,
Present.
Mr. Bardsley. Here. Mr. Courtney. Here. Mr. Dawes,
Present.
Congresswoman Brooks.
Here.
We have a quorum.
Thank you. So for today's agenda, we're going to be discussing a really critically important topic on public health funding. And I hope that we'll have a robust discussion after our presentations today. Our agenda today will have public comment, summary, and remarks from selected commissioners. We will then, and Shane will help manage that for us and lead that. Will be Dr. Box will go over a governance structure primer for us. We'll have public health funding and financing presentation by Shane Hatchett. And then we'll have time for open discussion on funding. And then we'll do a wrap and adjourn. So again, the topic of public health funding and how we invest in public health and how the funding flows and the sustainability of funding cannot be a more important topic that is fundamental to our ability to have a strong public health system in Indiana and to serve everyone across the state. So I do look forward to it. To start out, I'd like to turn to Senator Kenley for opening remarks since we last met.
Well, thank you, Dr. Monroe. You know, in the legislature, we've received so much materials in this process already that I guarantee you that most legislators would have quit about 3 hours ago. They have a very short attention span over there in the State House on the third floor. And, but frankly, I am so excited about the quality of all of the people that are serving on this commission and their experience and their willingness and ability to help us. And I just want to say that we're kind of getting through the education phase. There's going to be more discussion and more input from you. So please keep coming because we need your help. One of the things that Dr. Box has worked with me to do is we've contacted quite a few different interest groups. And I know we're going to go talk with the Association of Indiana Counties, but many groups who keep their finger on the public situation here in the state of Indiana. And we're going to be making little presentations to them along with asking them to support our efforts and to realize the importance of what the governor has asked us to do here. And all of this is with the idea in mind that as we come out with the report next fall and then probably go to the legislature with not only suggestions about improving Indiana's public health system, but with funding it up to where it needs to be, we want to have those folks in line with us, because in the end, if we can't sell the legislature, the work is in vain. I hate to be that blunt, but that's just the way it is. And so we need to continue to work on that. And if any of you have thoughts or ideas, or if you even have conversations with individual legislators and you think that it would be helpful, for example, if I would call them as a legislator, I'm more than happy to do that. So thanks for what you have done, but even more, thanks for what you're going to do, which is going to be quite a bit. Thank you.
Now, we're just warming up here, I'd say. So I'd like to thank you, Senator Kinley. Congresswoman Brooks, I'd like to turn to you for some comments.
Well, very briefly, and thank you so much for the opportunity to participate. And I am participating as a citizen advisor, and because I no longer have any really official roles except that. I will say, when I was in Congress during the 8 years I was there, the opioid crisis was raging. And I saw the newspaper article this morning about the opioid crisis is back, and that the amount of overdoses is still, we really never conquered the problem. Addiction's always been with us, but the opioid crisis took so many lives, and we all focused on it for quite a while. And we were turning the corner in many ways, but I think the isolation and all of the challenges with this pandemic, I think, have led us back to an opioid crisis. And I asked Dr. Box about it this morning, and that there's a 30% increase in overdose deaths in Indiana this year. And so we're going back in the wrong direction. And so I just wanted to put that back out there, because I think while we're wearing masks, and we need to be wearing masks, and we are in the middle of a pandemic still, there are so many other health crisis and situations happening. And I think the opioid crisis brought our state and country together in many ways around a public health issue that we really hadn't seen before, in not very much. And I also want to thank for giving us the article on syphilis. I mean, not something we all talk about very much or think about, but we know we've had hepatitis outbreaks. We've apparently have a resurging syphilis problem in the country. And these are just all important public health things that we have to be mindful of, not just the reason we're wearing the masks.
Thank you. It's a great reminder of why we're here and looking to the future. And as I'd mentioned before at other commission meetings, there's a lot of national attention actually on Indiana. Folks are really interested in how Indiana has structured the commission and the work that we're trying to achieve. And with that, of course, this is a national conversation, because every state is starting to take a look at how might they move public health forward. So to that end, wanted to let you all know that the CDC Foundation, which I lead, in collaboration with the Association of State and Territorial Health Officials, the National Association of City and County Health Officials, and the Big City Health Coalition, we are going to be sponsoring a series of virtual national summits for the conversation. The first one will be December 6th, virtual meeting with a plenary sessions from 11 a.m. to 2:30 Eastern time. I'm starting to tap speakers from Indiana to be on panels, and so beware, because this is a series of summits. So you all will get tapped along the way, and we'll have the focus on workforce for the first one. And then we will also have in the same day some breakout groups that will have facilitators, and will be by invitation only, to dive deep into some of the topics around workforce. And then we'll have one in January on data, one in February will be focused on governance and finance. And then in March, we'll be focusing on community engagement and partnerships, like with the private sector and so forth. They will be recorded, but we will make sure Shane or we can get out the links. I'll make sure that the invitation, you guys probably already have it, but to make sure the links are there. So so Mindy actually just agreed to be on one of the panels for December 6th. So she's our starting point for Indiana, representing the national conversation as well. So wanted to mention that. So with that, I would, do we have a motion to approve the minutes from our last meeting?
Motion to approve.
So motion, do we have a second?
Second.
Shane, did you get the,
Yeah.
Names?
Dr. Wells, motioned and Mr. Barnes and
okay, all in favor?
I,
Any opposed? Okay, so we have our minutes approved. And now we'll move to the public comment summary and remarks from selected commissioners. And Shane, if you would give us, would you discuss the public comment summary?
Sure. So as we talked about at the last meeting, we launched the form for folks to provide public comment to the commission. Again, one of the many ways that we're trying to make sure that folks have access to not only the commissioners, but staff of the department as well, and making sure that we're considering input from a variety of sources. We had 14 comments from the period of October 18th when the survey went live to November 4th. 4 of those were related to COVID vaccine mandates, and in particular being opposed to those. Obviously, that's an area that this commission's not necessarily focusing on. However, in the interest of transparency, wanted to share that we did receive those. 3 comments focused specifically on the healthcare workforce and delivery system topic area, which is obviously what we talked about at the last session, and we'll continue to have conversations about. In particular, individuals were focused on eliminating nurse licensure barriers for foreign educated nurses, as well as overall challenges that healthcare providers are experiencing, particularly now related to burnout and pandemic fatigue. We had 2 emergency preparedness related comments, one specifically focused on developmental disabilities providers, which is a group that our department has been focused on throughout the pandemic and making sure that we actually kept them in mind as we were dispersing PPE. However, this individual had additional feedback to provide related to that. And the second commenter had an overall feedback related to additional funding and emergency preparedness in general. The last several comments are a little bit broader. To be transparent again, 2 were related to benefits for state employees and contractors at the Department of Health, and making sure that there were additional services available. And then 1 was specific to a grant being turned down at the local level that they felt would have been of benefit to the community. All of these are synopsized in this form. We will continue to write this for you at each of the meetings, and this document itself will be posted on the website so others will have access to this specific information as well. We did try to keep it at kind of an anonymous level so that they didn't feel that they were being called out in any particular way. But I think that if you have feedback for us and how this is presented, we're certainly open to that. But we tried to strike the right balance, not overwhelming you, as Senator Kenley pointed out, but also giving you the right level of information for action.
Very good. Thank you, Shane. So next, Dr. Welsh, some comments for us on the public health system and your thoughts?
Thank you very much, Dr. Monroe. I'm very excited to get this information to this group in particular. A year ago, when we were experiencing the gaps in public health service in the United States, the AMA took on at their inner meeting the challenge to look for ways to how to better that public health infrastructure and help physicians in public health and in just healthcare to work better together. In addition, there was resolutions passed at their House of Delegates asking to look at capabilities in all jurisdictions of public health, not just the big cities, but everything down to small counties like the ones that I represent. And also, it's very interesting, the comments you made about the upcoming program, because many of the things that you're planning to discuss at these forums is a part of their challenge. Looking at data, looking at funding, looking at workforce issues. They used, to give you some background, once this was passed, it was then assigned to the Council on Science and Public Health to put forth a report looking at these problems and looking for solutions. And for transparency, I'm a member of that council. So when this came forward, I had my hand up first and I said, let's do this thing. And I had a little bit of help along the way because I had the work of Dr. Halverson and the Fairbanks School of Public Health when they looked at this at a state level, similar way, and they had their report. So as soon as that was available, I forwarded that to my council colleagues. They really liked what it said, and using that plus the 10 essential public health services, that formed the foundation of where things started. The AMA board was very engaged in this process, and they actually put quite a bit of money out to gather resources, gather information, including interviewing people from across the country who are involved in public health, to looking for where are the gaps, where are the problems. And again, I kind of called on our good friend, Dr. Halverson, to be involved once again. So I'm guilty, if you're wondering who put your name in the hat. So this past week, the AMA intermeeting met, and the first of a series of reports was passed and approved by the House of Delegates, the AMA. You don't need to take notes because everybody will be getting a copy. I dropped one off to staff earlier. And just to hit the basics, they're looking at ways of making sure that workforce is emboldened, that we have a deeper bench for our local, state, and regional public health entities. Looking for funding, not only when there's an epidemic, but a consistent funding so that those in public health can perform the services that are not only needed, but essential in our day-to-day living. There's that old saying, I think everyone here knows, when the public health services are doing their job, you don't hear about it. Yeah. You don't, when the water's clean, when the sewage is taken care of, when there's not problems of people getting sick at restaurants, you don't hear about it, but that means they're working. Just some basics is looking for research, looking for funding for research and for services to be given. One of the key things was communication, how to communicate between the public health service individuals and those in practice and the public. And communication is a big thing that I've carried at different organizations. Someone asked me earlier, I have on my lapel a nautical flag called Kilo. Kilo, if you're communicating between ships at sea, it stands for the letter K if you're spelling out a message. Standalone, it means let's communicate. So that was a key part. And how do you communicate? You need to get the information. And so one of the things that they called on is to have the EHRs, which all the physicians are using now. How can we draw information from those EHRs for actionable things in the public health sector? How do we get those in the public health sector to communicate with their local docs so that they are aware of there's an outbreak in syphilis in an area, that there's a problem with hepatitis C, so that they're aware. We need to, so those providers know, we need to ask, in addition to our regular questions when the patients come in, we need to ask these special questions. We need to pay attention to public health problems. Are they up to date on the immunizations? And we need to improve how public health communicates with those in healthcare in general. And also between physicians and public health and our hospital systems. Because a lot of times there was a breakdown in communication we found in this last 2.5 years. One of the other key things this group would be interested in knowing, that the AMA will actively oppose limits being placed on the authority of health officials trying to do their job and encourage evidence-based measures, whatever that might be, given the circumstances that they find themselves in. There's a call to get all interested stakeholders, like what you had talked about doing in this listening tour, get them all involved, because everybody's got some good ideas. And how do we incorporate that? And what's good in Chicago may not work in Franklin County, Indiana. And we have to be able to be nimble, and we have to be able to adjust. And I could, as you can tell, I could talk for hours on this. So I would ask people to take a look at this. If you have questions, reach out to me. I'll be happy to discuss. This is a first step. This is a first in a series. And since I'm on the council, you can rest assured that I will continue to hold their feet to the flames, if you will, to get the next and subsequent reports. And the things that I think are going to be important coming out of this and out of our work is to increase our public health bench. Everybody loves the movie Hoosiers. And they won, but they had a really short bench, even had to play the ball manager at one point. Too many of our counties are having to play the ball manager. And we need more folks in place. And I know right now, a lot of them are stressed and there's been turnover. And we don't have a large pool to draw from to replace folks who have burned out or have had enough. Secondly is increasing resources. Resources, that can mean a lot of things. That could be everything from PPE to instructions to directions. I can tell you, I appreciate our Indiana State Department of Health individuals from Dr. Box on down. When I've had questions through this and they've been extremely helpful, it is as recent as yesterday. We need to make sure that we get information out, that we can get education out to our public health folks, to our healthcare folks, and to the public. And if we do that, I think the public can then help us and the healthcare individuals can help us do the job that's necessary. And data access. There's a lot of things we don't know. And early on, I sat in on calls with the AMA staff and the CDC, and it was interesting phone calls. And there was a lot that we had to learn. And there was a lot we've learned in the last two years. But there's a lot we need to learn beyond COVID. And we need to keep our ears open. We need to keep the conversations going. So when COVID is past, that we continue to do the things to strengthen the infrastructure. That's one of the reasons why I'm here. That's the reason why you're here. And we need to, everyone prepares for hurricanes when they hear it's going to be there in a day or so. And many times after they're gone, they kind of forget, unless they were hurt themselves, drastically. We need to make sure we continue to communicate with the public and with our stakeholders. The iron's hot right now. And I know I can tell you the AMA is willing to help. I can tell you the American College of Surgeons is willing to help. And we need to graciously take the help that we can get so we can move the ball forward. But I'm very excited, as you can tell, and I'm looking forward to the next things and any suggestions. And I'll be taking information from here and sharing it with the council. And they're very excited about our work here. And but things that you would like to see in the next report, let me know, because there's more to come. And as long as I have a say in the matter, it'll keep coming.
That's excellent. Excellent. Well, thank you. Thank you for your passion. Oh my, comes through. Terrific, terrific work. And I'm taking notes because I'm thinking we're going to need to get some speakers on the national summits for the AMA about this work as well. So Kara, can we?
I have a quick question for Dr. Welch.
Yes.
Does the State Medical Association, so our local AMA for the state of Indiana, do they know you're on this council? And
Absolutely.
do they, but will you be presenting to Indiana physicians about your work?
We're doing a series of things. There's the AMA delegation, which I'm a member of also. They're well aware. They're actually the group that approved this. So they're aware. Our State Medical Association is very engaged, and you can check with Dr. Box, and they're engaged with the State Department of Health, very much so. They're working with the county health officers, very much so. They're very active with the state legislature, as Senator Kennelly can attest. So they're aware, and I can take your thoughts to them to push things out even more. With my position on the council, they had a research, they continue to have a research page, if you will, on their website having to do with COVID-19. And I work closely with their staff to make sure it's up to date and accurate. And we kind of vet things so we don't take it on the first time we hear of something. We want to make sure it's accurate and it's up to date. So they're very engaged, they're knowledgeable, and I can assure you they will make sure this gets passed on.
Great, thank you.
Thanks.
That's terrific. So,
Yeah.
Dr. Field.
I may not chime in as much, so you don't select me for your series there. Just kidding, anytime. Well, I appreciate the opportunity to kind of share some perspective from the rural health areas within Indiana, specifically as it pertains to public health, population health, and then health from the perspective of healthcare clinicians as well. So I think in Indiana, we do a lot of focus on hospitals, which is obviously very critical to the survival of many of our rural Hoosiers across the state. But I think that at times we are extraordinarily reactive in our approach to healthcare, and at times necessarily so. So, I mean, I don't think any one of us expected to be in a pandemic. We obviously have to react to a situation that we've never experienced and try to learn from that moving forward. However, what I think that we should be looking at are ways to explore more opportunities to focus on preventative health. We need to look at healthy lifestyles, and that really should take a population health perspective. In collaboration with public health and frontline clinical care as well. So I don't know how you operate and practice in one area and not overlap in another. And so we don't do this is not unique to Indiana. Just as a nation, we don't do well in funding preventative medicine and preventative medicine measures. Dr. Box and I talked about this a little bit yesterday and previously. We have programs in place that demonstrate the benefit and the effectiveness of preventative medicine or preventative funding. The Perinatal Navigator program launched in Indiana has been an incredible benefit to reduce infant mortality rates across the state. I think that is a clear demonstration of how public health or preventative health funding can demonstrate long-term benefit to the overall health of in our situation, Hoosiers, not just rural Hoosiers, but all Hoosiers. We don't do a great job with that. Our dollars and cents go to what's happening right now and how do we take care of you, in the situation to keep you from dying, and which is of course as critically important. But we also need to focus more on program development and initiatives that prevent us from getting into a situation that we likely could have prevented. When it comes to financial resources in our rural communities, we struggle greatly. A lot of our rural communities are of aging infrastructure and are limited in human resources from both the provider aspect, but even the non-clinical aspect in providing services for Hoosiers across the state. And so we're almost at a catch-22 or significant barriers for moving forward. How can we focus on preventative medicine if we don't have the workforce to support it? And then when we look at public health and specifically local health departments, a lot of our rural communities have part-time. I think we saw in last month's presentations from the Bowen Center. A lot of our health departments don't have a full-time person. That can translate into a lot of errors and/or missed responsibilities. If we don't have the physical capacity to focus on initiatives that health departments are responsible for, we can only do what we can do. And some things will likely have to go by the wayside. I just personally don't know. I'd certainly love to learn more about the discussion we had, I think it was last month, on the regional health departments and how that could support our rural communities. I don't know that that's the answer, but my concern would be, are we going to funnel these resources that we currently have, albeit the few resources that we have, into a regional location and then end up losing sight of some of our smaller rural communities where now we don't have any resources or we don't have as much robust conversation going on. So today we see, and I echo Dr. Walsh's comments, we see poor communication between our local health departments, our hospitals, our really any healthcare provider in our rural communities. And everyone is likely working towards the same initiative that's independent of one another. And so I do think we could, even we might have a number of resources that are working on the same initiative, but they're not working together. And so it creates a lot of confusion. It creates a lot of spinning wheels. And I think we do the same thing with our funding at times as well. So we're gonna issue funds to this organization to focus on this initiative, maybe unknowing that another organization has also received funding to focus on the same initiative. We're experiencing this today. And so although that's very challenging and difficult, and oftentimes those funding sources have different objectives. I think if we can start collaborating more on key initiatives, preventative health, we're going to get a bigger bang for our buck on where those dollars go, how they're utilized, and then the long-term outcome that we'd really like to see from that. So.
No, thank you. Very insightful. Any questions or comments before we move on? All right, again, thanks. And we now, Dr. Box will talk to us about governance structure.
Thank you. So we heard last time pretty loud and clear that even though we had saved the governance infrastructure and services to December, there was not maybe enough basic knowledge to even understand how our public workforce and our funding, interacts with that. So I'm just going to do a really brief primer, which will be an introduction then to the funding aspect of this. So we talked a lot at the commission meetings about the essential public health services and the various degrees to which Indiana's 94 counties are able to actually provide these services across the state. Sometimes that comes down to the size of the department's workforce, which, as I can imagine, is directly related to the funding for that local public health department. As you'll hear in Shane's presentation, Indiana relies very heavily on federal funding to support our public health at the state level, about 68% of our funds. At the local level, most departments are funded through their local property taxes. One of the challenges for many of our local health departments, what they face in their current structure is that their funding is controlled at the local level by the local elected officials. And this means that the funds must pass to them and be appropriated by the councils and reviewed by the commissioners. Throughout the pandemic, we have had some local health departments turn down supplemental funding, large amounts of money that we would be able to give them because of challenges in being able to, number one, stand up those programs to meet the requirements of that money or that grant, because oftentimes they didn't have enough personnel. Number two, unfortunately, hiring people for just a short 2 to 3 year period of time for which you have funding becomes an issue. And I'm sure that our county councilor commissioners can talk a little bit to that. And number three, when we do give funds to the local public health department, sometimes those supplant other funds that they are already receiving, and they have a concern because those are the ongoing funds that they need to continue to rely on to run their local health departments. So this really becomes a catch-22 that the local health department needs additional resources to handle things like the huge workload that comes along with the pandemic, but they can't risk losing those basic funds that they require on a regular basis. And also there's a hesitancy, as I said, to hire those additional people when we know that funding is only there for this very short period of time. And that's true at the State Department of Health level also. So we really need to be able to challenge this narrative. And one of the best ways to do that is to ensure that Hoosiers in every corner of the state, including those in our elected positions, truly understand what public health is and what we do. And I think this is a resounding comment that we're hearing from everyone on the commission. Many people's understanding of what public health is really just relates to COVID, right? It's to masks and mandates, but it is so much more. We have had to rely on our local health departments for testing, for other things, and for the vaccines. We've mentioned previously that local health departments are required by statute to do many things, and these are some of those basic local functions that I presented in that very first meeting that we had that I wanted to revisit. But more importantly, in your packet, Mindy Waldron and her team has gone through and written through, based on statute, every requirement for every local health department in the state of Indiana, and it's pretty overwhelming when you look at it. So if you have a moment to look at that, I think that will broaden your view of what public health is and what they're mandated to do here in the state. But public health isn't just waiting for a crisis to occur, right? It's preventing epidemics, preventing disease, preventing harm and injury is what we're really about, especially things when it comes to our children and to our families. And our team works to make sure that we can prevent those injuries and promote and encourage health behaviors that are really good, like diets and exercise, like wearing a bicycle helmet, like making sure that families have their child in the right car seat and that it's installed appropriately. Those are the things that we in public health do on a daily basis.
We work to increase access to health services and education, like to reduce infant and maternal mortality rates. And I know several people, I know Dr. Veal was there yesterday at our Labor of Love. And public health works to ensure that children can receive those routine childhood immunizations, our vaccines for children, which is so critical for those families that can't afford those vaccines, to protect them from the diseases like measles and mumps and rubellas and chickenpox and whooping cough that we lose children to every year because they become infected with whooping cough. I hear about the importance of public health every time that I meet with Hoosiers, like Sally Tuttle, who's the vice chair of the Indiana Native American Indian Affairs Commission. She shared with us just how important it was to her family to be able to access immunizations and care through her local health department. Commissioner Tuttle is an enrolled member of the Choctaw Nation here in the state and explained that getting her children into a provider can be very challenging for her at times. And so if she didn't have her local health department to fall back onto, they would fall behind in their immunizations and risk prevention, which is so critical. And this example just shows how important public health is, especially to our disenfranchised populations across the state. But keep in mind that some of our local health departments are very, very thinly staffed. We've heard all about that, and I won't belabor that. They have only a handful of full-time employees, and some of them couldn't even keep their doors open in the early part of this pandemic. They basically shut down. So no childhood immunizations were getting done. They weren't there to pass out personal protective equipment to our long-term care facilities and other people. They weren't there to be able to do testing. Quite frankly, our current structure has created really a system of public health across the state that is not consistent from county to county. Today's presentations will actually provide a better understanding of the funding challenges that many local health departments face. As you listen, please listen with one ear and then with an eye to the fact that our next commission meeting will be about structure and services and governance. There are several models with regards to public health across this country. At the state level, the State Department of Health can be a freestanding or independent agency like the Indiana Department of Health, or it could be a part of a broader super agency or what we call an umbrella agency, which includes Family and Social Services Administration and sometimes even other agencies. Most local public health departments in the US are what we call decentralized. In those cases, local health departments are led by local governments, which make most all of the fiscal decisions, and the employees are local government employees. This is Indiana's current model, and it is the overwhelming model for the United States. Another option is the mixed approach, in which some of the local health departments are led by the state and some by local governments. A half a dozen states, including Tennessee, follow this model. We also have the centralized approaches in which all local health departments are units of the state government. In these situations, the state makes those fiscal decisions and the employees are state employees, and about 10 states are either centralized or largely centralized. And the final model is a shared structure in which all local health departments are governed by both state and local authorities. About 4 states follow this model. And I bet that's pretty interesting during a pandemic. This map basically just breaks down. I wanted you to have this to refer to, but the orange color here, not the darker reddish orange, but the orange color represents those states that are decentralized, like the state of Indiana. So we're going to further dive into these models next month, but as you listen today, please understand that how public health is structured frequently depends largely on how it is funded. Thank you.
Thank you, Dr. Box. Any questions? in that presentation? It shows how diverse our country is, how complex actually governmental public health is. So Shane.
Dr. Monroe, I love that presentation, Dr. Fox. I'm just wondering do we know the last time we actually did a comprehensive update on the public health laws, and in particular, how old some of these statutory requirements are?
I think 92 was maybe the last time we updated anything. Minnie's shaking her head, so there's our expert, but it's been a long time.
A long time. Okay, thank you.
So as a follow-on to that, Dr. Monroe, been 30 years since this has been done. So on this page here where it says, I don't want to derail the conversation, it says railroad camp car.
That's a new one. That's a new one.
Yeah, that's actually a newer statute.
That needs to go.
That sounds like 1890 or not 1990.
Exactly.
Yeah, it does pay to do a refresh from time to time. Okay, so Shane Hatchett's now going to take us through the public health funding and financing. A lot of work has gone into this presentation, so thank you.
Thanks, Madam Chair and members of the commission. As many of you know, my name is Shane Hatchett. I'm the Chief of Staff at the Department of Health, and I'm actually really excited to be here today to talk to you about this topic, although I recognize that finance is often a topic where people's eyes glaze over, so I will endeavor to keep you awake during this. I want to start by just framing this a little bit. In 2008, then Governor Daniels remarked in his State of the State speech that Indiana's local government structure would be easily recognizable by a time traveler from the 1800s. And I think so too, that is the way public health is financed as well. I know we hear frequently in government that resources we receive are simply not enough to do the work we're charged to do. But I hope to empirically show you today that we really see this in public health and that the time is right for us to have a conversation about changing the way public health is funded. Just a quick note of thanks. In preparing for this presentation, we spoke with a variety of knowledgeable individuals who are familiar with local government finance and public health operations. I'd like to thank them as well as our partners at HMA and of course our excellent team at the Department of Health Finance Office. As I alluded to at the start, we know that the public health system is underfunded, but this is further compounded by the fact that funding is so uneven and distributed unevenly. A 2012 National Academy of Medicine report identified that an additional $24 billion is needed to fully fund basic public health services at the national level. I recognize that $24 billion sounds like an exorbitant amount of money, but when you take two things into consideration, I don't think it's actually that significant. The first being that this is at the national level. So we're talking about all 56 health jurisdictions across the country and territories. The other is that in 2012 terms, 17% of the gross domestic product was spent on healthcare. So in raw terms, that's $2.8 trillion. It's not quite the same comparison. We know that the work of public health reduces healthcare expenditures, yet today our system is designed to focus on healthcare and not the upstream investments that will reduce those costs. When we further look at, when we further analyze national funding trends, we find that Indiana tends to be in the lower third to bottom quartile, depending on what the measure is. The CDC program funding measure includes state and local CDC grants. For example, some counties receive direct grants that either are competitively awarded or granted based on certain statutory criteria. One note is that these data do not include COVID funds awarded by CDC, which have been carved out separately. The CDC COVID funds were largely awarded based on population, social vulnerability indices, and sometimes other criteria. So in that regard, Indiana actually tended to fare better. It's important to note that much of the COVID funding we received came with requirements on how those funds were distributed or granted further, such as certain percentages being dedicated to local health departments, schools, testing, vaccinations, or the very important work of health equity. While we certainly could not have combated the pandemic without those resources, they did at times present challenges for us in how best to build cohesive programs that met not only our objectives, but that of the federal administration. Compared to our neighbors and exemplar states, Indiana spends less per capita on public health. Nationally, per capita public health spending is around $91 per person, yet Indiana is closer to $55 per person based on most recent comparisons from the America's Health Rankings report. Focusing in at the state level on appropriations to the Department of Health, our budget is predominantly funded by federal grants. Approximately 66 to 68% of our funds come from federal partners. In the past 2 years, however, that share has increased as we've received increased pandemic-related funding, which is reflected here in this $534 million for state fiscal year 2022, which is what we're presently in. Often Dr. Box is fond of joking that when it comes to a pie chart of the state's budget, we are the thin line that separates education, and Medicaid spending. So at $534 million for state fiscal year 22, we represent just 1.2% of the state's annual $43.6 billion operating budget. Our next largest source of revenue is the Tobacco Master Settlement Fund, which combined with other dedicated funding sources accounts for 20% of our budget, then followed by 3% of general funds appropriated by the state. For us, 2023, we're appropriated on a biennial basis. 2023 is virtually identical as well. I did want to take a moment, though, to give credit where it's due. We are excited that this year the Indiana General Assembly appropriated $50 million for the Health Initiatives and Challenges Grant Program using ARP money, which will allow us to substantially reach out with community-based organizations and local partners to make significant investments in public health prevention and programming.
So Shane, on this circular chart here on page 10, it says 76% of the money comes from the federal government. Now, is most of that money, does it go to programs like WIC or something like that, where it's already spoken for, it's used for a certain specific purpose, and there's actually no flexibility on our part in terms of deciding how to use that money?
Sure, that's a great question, Senator Kenley. If I can actually turn you to your next slide, we
Okay.
focus on expenditures, which I think gets at your question related to the discretion that the department would have in terms of that funding. And what you'll find is that actually 29% of the money that we receive is actually for women, infants, and children, which makes sense. That's a largely federally funded program. But to your point, that money is already identified as to how it's going to be spent and goes out the door. Just above that is the 45% that is attributable to Health and Human Services programming, where we do find that there's more flexibility in terms of how we distribute that money. But for example, it's oftentimes through cooperative agreements with the CDC or even HRSA programs that tend to have statutory requirements placed around them at the federal level or in that agency's regulations. So really the only true block grant that we get from the federal government is a couple $1 million a year. Most everything else has some type of program requirement around it. Does that answer your question?
Well, it does, but within the 45%, and maybe you could, if you wouldn't mind looking at that and just identifying that for me so I can get a stronger feel
Sure.
for how that works, and maybe just send me an email and send it to everybody else on the commission too. I think that'd be helpful in the bigger picture. If we're going to have to go to the legislature and talk about different mechanisms of funding and maybe even a different structure of delivery, we're going to have to show them that we don't have any room to do that with the current funds. And so I just want to make sure I understand that point.
Sure, and that's a great point to make. So we'll work with our Office of Finance to get that taken care
Thank
of
you.
and sent out to the commission. Before I move on from the slide, though, I did want to highlight two grants that are appropriated at the state level to the health department, and we then in turn issue those to local health departments. As we were discussing different funding mechanisms with local health departments, we did consistently hear that the local health department account and the local health maintenance fund grants are actually really useful resources for them because they tend to be more of a block grant in nature. The local health departments write a budget to that, submit it to the department, and the councils tend to understand that that's coming, and there's less consternation or concern about those funds, even though what we've seen and heard in other grant areas is that there's often a bit of skepticism associated with that. So I just wanted to carve that out separately, that 6.9 million or so, while small, is very vital to what the local health departments do.
Shane, if I may,
Yes,
on
Dr.
behalf
Walsh.
of the small local health departments, thank you. It helps us meet our mission considerably. Thank you very much.
You're welcome.
So, question, so that 6.9 million then is somehow spread throughout the state to the local health departments.
That's correct. So in statute.
And how is that allocated?
In statute, it's the population criteria are elaborated on. So generally, it's a range of population, and counties falling within that range get a set amount by the
see.
statute.
So for instance, where Dr. Welch is, it's probably pretty small.
Yes.
Even though he's very thankful for what he gets, but compared to Marion County, it's minute. An accountant would say it's not material.
Well, material to them, but comparatively, I think
I
your
understand.
point's well taken.
Yeah, okay, thanks.
Can I ask a question on that? Because I think this table showing the per capita range is really interesting because our health needs are almost the same all across the entire state, but
Mhm.
our investment is remarkably low. And I'm sure Jefferson County, where I live, falls into that $3 to $5 range per capita. That's not much investment. How do we get more consistency about what we invest in public health all across the state? And remember, one of the very first sessions that we had, we talked about how our zip code shouldn't dictate our health.
Right.
This really demonstrates where our zip code is dictating what our health outcomes are.
So I think that's a great point, Mayor Courtney. And in fact, you're kind of setting the stage up for me, so I appreciate that. What I want to highlight, though, just to be very transparent about this, is that chart is the property tax draws per capita. So it's not necessarily reflective of a health department's entire budget, because as we dug into these data, we really truly began to appreciate the complexity and the myriad of sources that local health departments receive revenues from. What we wanted to demonstrate here is that in aggregate, about 60% of most health departments' local budgets come from their property tax draws. And as such, when you normalize that for population, that's to your point where you see that wide variation in terms of how much revenue a local health department is receiving. We focused on the revenue side as a proxy measure for the overall budget because we didn't have a good way of actually getting at the budget and the expenditures pieces, because this is what the Department of Local Government Finance actually certifies as the property tax side of things. And we know that because it's such a significant source of funding for local health departments, it's kind of a good way of getting at the overall budget. And so many local health departments also use, in some cases, a local option income tax, user fees, or some other fee sharing structure with the county. Some of that's set up in statute, though, and so it's really regulated by the General Assembly. And of course, as our county commissioners and other folks on the county council would know, having a really good relationship with those governing bodies to be willing to partner and share in some of those other resources. But the reason that we really focus in on this property tax piece is that obviously, as counties approach their maximum levy for property taxes, that then kind of creates compression for the local health department's ability to continue expanding resources and their budget. So I'm sure that as we go through this, I'll probably get more at your question, but does that answer it at least for now?
No,
Okay.
thank you.
Dr. Kane?
I think that's what's even more of a threat is that there is some intention by policymakers to even lower the property taxes even more because of what they believe is this infrastructure bill and additional funding coming in certain areas like roads, bridges, and things of that nature. And that's why they want to lower the property taxes. But unfortunately, that will not translate into getting more money into public health. It will be less money getting into public health. So that's the future threat, but it's coming very, very soon.
I did want to note, just for this group's awareness, most local health departments or county health departments have a separate health fund. So that money is non-reverting and it can build up over time. However, what we find is that counties will adjust their tax levy accordingly based on what the current year's needs are. So that does not necessarily translate into, amassing a significant amount of capital. Additionally, and I thought this was just interesting, there are 2 counties that use no tax levies to support their local health departments. They do that entirely through other fees and arrangements.
Oh, I'd love to know which 2 counties are they? You
That'd be
just
Wayne
can't
and
leave us
Warren.
like this, not telling them.
And then, of course, as Dr. Kane is acutely aware, Marion County is very different in this regard. And so we've either called it out or excluded it from kind of some of these aggregate calculations because of the unique structure of the Health and Hospital Corporation under Unigov. That's much different than what most local health departments would experience. So kind of more to what Dr. Kane was mentioning here, it's not necessarily all gray skies on property taxes. Over time, these tend to be consistent and steady, and so that provides local health departments a bit of consistency in terms of building their longer term budgets. On the other hand, though, it does mean greater reliance on other revenue when there are spikes in expenditures, such as the coronavirus pandemic, or if there's a specific outbreak within a community, since they're not able to quickly raise capital by raising property tax revenues if they're already at their maximum levy. This also presents challenges when there's a significant economic shift, such as a plant closure or some other major employer in the area leaving. If the aggregate assessed value of property in the county drops, the maximum levy accordingly drops, and the Department of Local Government Finance will not certify that county's budget at a higher rate. So what this translates to is decreased funding across the board within a county if there's not a continual increase in terms of a gross assessed value of property. So what we heard from some folks is that the only way to really continue building this tax base is to have new housing additions continually built, or expanding quality of life or amenities in a particular area that draws people in to ensure that folks are very interested in buying property there so that the assessed value remains high.
How frequently is that assessed? Is it annual or is it less frequent?
I apologize. I don't know, but I will look into that for you. I don't want to give you a bad answer.
It's outdated information. But it's based on.
Yeah, I didn't get into as much that conversation with the Department of Local Government Finance as much as the budgeting process, but we can get that for you and share that.
Actually, properties are assessed and then they're supposed to apply trending rules every year. And then in addition, each county is subject to a state review of their assessments either every 4 or every 5 years. And then in addition to that, if you get a lot of citizen complaints from a certain area about the uniformity of the assessment, why the state can do a specialist audit of that. We kind of restructured all this when we did the property tax reform bill.
That's good.
With the constitutional limits a few years ago, but the trending rules are controlled through the Department of Local Government Finance, and they're pretty precise about how you're supposed to assess every year on the trending.
We decided to bring Senator Kinley back since he started all of this. Thanks for the question, Dr. Veal. So what I want to illustrate in particular, though, about this example where a major employer closes in a particular area and property value drops, what you find is that the population size doesn't necessarily decrease, or the services that they're looking for doesn't change. And yet the local health department's revenue, primary source of revenue in most cases, has significantly changed. And so now local health departments are required to do more with less. And this ends up being a little bit of a self-fulfilling prophecy then, because when you are not investing in local public health programming, we know that that can often lead to places, issues where employers don't want to relocate, or individuals may not want to live there any longer. And so it becomes a bit of a feedback loop in a negative way, where we find that some communities struggle to get out of that. And so as we focus on our communities being quality of place and drawing people in to want to live there because of the unique characteristics, that's one of the things that has to be taken into consideration. And I think that, you know, if I may be candid, this is probably one of the reasons that local school funding was significantly altered in the early 2000s, realizing that as a function of what the local community's quality of life is like, that it should not necessarily be dependent upon the zip code's ability to fund that particular essential service. So again, I'm not going to belabor this self-explanatory slide, but as you can see nationally, local health departments in Indiana are funded differently than what we would see at the national level. So there tends to be significantly more federal and state funding for local health departments than we have here in Indiana. And of particular note is also that nationally, Medicaid and Medicare claims account for 10% of a local health department's revenue, which we'll talk here in a little bit about how that looks specifically in Indiana. Yes, Dean Halverson.
Shane, I think it's really important for the commission to understand that the local health departments in this country primarily receive that federal funding that you mentioned through the state health departments, because aside from the largest health departments in the country that have a statutory provision that allows them to receive funding directly, the funding from the federal government comes to the state, and then the state allocates the money to the locals. So the important thing here is to recognize that it's not just locals that are failing to apply for a grant. It's that they cannot apply for the grant. They're constrained by federal funding rules that don't allow that. So it's just an important issue that to recognize that this is not funding that's available.
Can I ask a quick point of clarification? So when a local health department receives federal funds, if they are passed through by the State Department of Health, does the county council still have to approve those funds to be allocated to the health department's budget?
Yes.
Under our current statute?
Yes.
Yes. Thank you.
So I actually went ahead and advanced because that's something that we'll talk a little bit about here, Dr. Maxey, so that's a great segue. In particular, our conversations with local officials and local health departments were really instructive in terms of their view of this and how it works at the local level. And as Senator Kenley alluded to, the budgeting process for locals is very regimented and reviewed very closely by the Department of Local Government Finance, mostly from a solvency perspective and in making sure that local jurisdictions and taxing authorities are, taking in as much revenue as they need based on their expenses. So what we find is that any appropriation to a county department does have to go through their county council, which would include grants and any sort of outside funding sources beyond what would necessarily be appropriated as part of their regular budgeting process. What's unique in this case, though, and something that very candidly at the state health department level we did not quite appreciate, is that the local health department has to first ask permission to actually get that grant. And then they have to go back once it's awarded and ask for authorization to hire or fill that slot with a contractor. And so when the council meets maybe monthly or sometimes more or less frequently, depending on the area, that can really result in some significant follow-on delays for program implementation on top of some of the challenges in general of just dispersing money and executing grant agreements and things like that. So where we at the state level think, gosh, it's easy just to grant out some funds to the local health departments, the actual operations of that is a little more complex than we had originally realized.
Shannon, I may just point out on that many of those requirements are mandated by the state to the local governments, such as the State Board of Accounts. So it's not the local municipality choosing to make the process more complicated. There's a structure there, particularly where there might be a compliance liability that might be undertaken. may require ordinance. There's just a lot of structural and consensus building elements that are mandated by the state when it's in regards to accepting funds.
That's a great point, Mayor Courtney. So that's not to say that councils are necessarily, trying to make the process more difficult, but that there are other compliance factors in play that, might be worth considering as we, as a group, are discussing this, particularly when it's from a state to a local jurisdiction. I think, to some extent, one could say we're good for the money.
Yes.
Shane,
Dean
one other thing, and that is related to the idea of, you showed on the page that shows local health department, national sources. The issue, I wonder if we could get a similar pie graph that would show national revenue sources at the state level. Because there might be some that would incorrectly assume that it's just that the state is not wanting to spend money on local health departments. The reality is that if we looked at Indiana's source, which you have on a couple pages before that, which is primarily federally funded, I think what we would find is that the state health department, the state portion of the funding for the state health department is substantially less than what we see in other states, and therefore the flexibility of the state to provide additional funding for locals is severely limited because they have their own state employees and functions to fund themselves, and therefore they have less discretionary funding for the locals. But so it would be helpful, I think, to show that in comparison.
Sure, we'll work on that for you and get that sent out.
Shane, let me make one, I don't want to prolong this discussion too much, but this is a pretty key point as we decide how we might, not only how much money we might need to raise and where we want to raise it, but how the money will be spent or appropriated out, or who will have the control over the decision as to how the funds are going to be used. As you look at the local resources of revenue in Indiana, particularly on the property tax, when you think of property taxes, most people just think of their homes and they think home values are going up all the time. But the reality is, because of the dual nature of Indiana's county residency construction, we have probably 10 counties in the state where the revenues are just going up, no matter what you do, because there is a market and there's a demand there for property. And in the other 80 counties, it's more of the opposite. And so their ability to raise money is actually diminishing at the same time that, for example, Central Indiana and Lafayette, Northern Louisville, Market, Bloomington, those are just, they're always going up. And so that's particularly true of the property tax and the local income tax. For example, in Blackford County, they don't have the ability to raise any local option income tax. They just don't have any wealth there at all to produce anything. So as we put the pieces of the puzzle together, if the state, if our recommendation would be that the state needs to raise more money on some basis and then it be distributed out, then since the state is raising the money, that gives the state more leverage and perhaps the Department of Health more leverage in deciding how the programs will be put together. So this kind of all ties together. And one of the big things that will be critical for us to solve correctly is that there is somehow a sense of fairness and equity in how the money is apportioned out and how it gets used. And then how, because if we don't do this properly, just the opposition of local government officials alone could sink any reform effort that you have. In other words, they can beat this by themselves because they'll have a good case. So you've got to take these, and we'll have to think this through carefully and use some financial experts. And I see from the people that you've had advising you, you've got some pretty good thinkers there, but we'll have to use their expertise to structure a system that will then support the substantive goals that you all who are in the healthcare industry might think are the ones that you want to have emphasized as our substantive values to be added in the state. So we need to be very careful about how we put all that together.
Agreed, and that's one of the reasons that as the department putting this together and working with different stakeholders, we wanted to provide kind of an agnostic approach to this that really facilitated conversation here today about what the commission thought was the best approach with some options on the table for consideration. But I think your point's well taken that throughout this process, we have to work with and engage local officials in this process because regardless of how one feels about it, Indiana has been and will continue to be a home rule state. And so, at the local level, we've made the decision since the dawn of our Constitution that most decisions are best made locally. And so we need to make sure that they're on board with whatever approach gets
This is
done.
very doable. But we just need to this commission just needs to be aware of the relationship that exists there and how it works.
Agreed. Congresswoman Brooks.
On slide 11, the shares from the federal programs, one thing that jumped out to me, and I'm curious because I don't know the answer to this, community health centers says only 3%. And I know, so under the American Rescue Plan Act, and I've just looked this up, Indiana, 27 community health centers are going to receive $108 million. And yet I'm like looking at community health centers I represented, they're not on this list. So, so it's a competitive, what is the relationship between the community health centers and our public health officials? And now you are different, I predict.
All right, okay.
Right? Okay, so, but I still want to hear your answer.
You're special.
I still want to hear your answer. But you are different. I know Marion County is different. And kudos to you, and you should get the most amount of money. You have the 108, and you should. But is there a model in Marion County that maybe might work? I don't know. What is the answer as to the community health centers? Because let me tell you, there is a big lobbying effort in Washington, D.C. always to fund community health centers in a big way. And I think we do. Now, it's not that it's enough ever, probably, but they're going to get a massive influx of funds here. I mean, and some smaller communities are going to be getting millions. Okay.
So
Is that?
So let me say that the smaller counties, it is so tough sometimes if you're a patient and you want a provider, if you're Medicaid, I don't want to accept the Medicaid patient. I don't feel I'm getting a good reimbursement for those type of services. So patients have to fall back on community health centers in order to provide their services if a lot of physicians are not taking your low income patients with poverty. So that's that's a really critical problem in smaller communities. I remember the point we couldn't get, it was tough to try to find someone to do deliveries or monitor a pregnant mother until they got the reimbursements, but it's a tough sale. So, and even in a large metropolitan city such as ourselves, the percentage of the poverty level for some of our clients, we have a wonderful Ashkenazi Health, and our community health centers are just fantastic, but trying to figure out how to do that distribution equitably. And I don't know what the formula is and how they do that.
I'm curious though, what portion of services that local health departments are doing, other than Marion County probably, are being done in the community health centers, or none whatsoever? Or is that a relationship? Because they're getting a lot of funding for healthcare, right? But are they also doing public health?
I think that's a really great.
I don't know.
I think that's a
So
really.
there are certain services that a community health center does not do as well as local health departments. If
I
we're
think-
having a STD outbreak, they may see an individual patient that's got for services, but they're not gonna be robust about doing that contact tracing, trying to find out who they've been in contact with and calling and being aggressive, trying to outreach to bring them in for treatment. So they don't go to that level of sophistication compared to a lot of local health departments.
So they're really delivery of clinical health for the most
Right.
part.
I
And
know
not
that.
necessarily as far on the prevention end. Now, what I will say is that clinical health has transitioned over the last 10 plus years to recognizing that population health is important. And as the federal government, which I keep believing they're going to do, would transition to paying for population health, that's when you'll see some of this really, I think, come together in a
Okay.
better fashion.
But my problem is that they believe, and wow, we're being recorded, right? So I'm trying not to insult. Insult. A lot of local health departments have been doing population-based services forever. We do it in our sleep. But we're going to find out that our community health centers, our hospital systems are really going after those dollars. They have better lobbyists, I guess, or the recognition of it. So they're going to get a lot of that money and they're going to trying to learn how to do this process when we already know it, but we're just not as effective and efficient getting the kind of dollars that should be going to us because we work along those levels.
And I think that if we funded our local public health people better, they could be that liaison to work with the hospitals, the FQHCs, the community health clinics, the not-for-profit organizations and the profit organizations, so that as Dr. Veal said earlier, we are all rowing in the same direction. We are all working on infant safe sleep with the same terminology, with the same words, but we're not all spending money doing little pockets of things that there's no organization. Right now, local health departments don't have that kind of skilled leadership that has the time to be that person to go out into the public and do like I've been doing for the State Department of Health, and that is bringing people together, right? Getting all of the right people to the table to work together. Mindy, would you agree with that?
I'm not sure I agree with that.
Well, you and Allen County do a really good job. I will tell you.
Well, there are a lot of counties that I think that can still do, they're fantastic. They can do a lot of good jobs. I think sometimes we have the problems of, I'm a hospital system. I got, I've got $1 billion budget. And their perception is, what can you tell me? And so, it takes a lot of work for me to get the hospitals together. Our primary care community health centers, we all agree. We meet quarterly and we say, we're going to do something together. The health department, community health centers, we're going to pick one subject we're all going to address. And so we do that, but hey, did they come willingly? No, sometimes we have to drag them to the table.
Virginia, I think you're just saying that because Brian Tabor isn't here.
Brian has been very nice to me, so I do have to be very careful.
Dr. Box, I do think, from my limited knowledge about the community health centers, I do think it's somewhat of a separate entity, and they're sort of scattered on a random basis in certain areas of the state. And we don't really know how big their budgets are, and Susan's referring to other funds that may become available. So I think, Shane, if you could reach out to David Reynolds and to a couple of those people on that list, they probably have a descriptive thing of saying, community health centers, here's where they are, here's how much each budget is. And we need to see on the map where they are. And then we need to think about, do we need to have some discussion about their situation in relationship to this total problem that we're dealing with? Or if we don't need to have a discussion, we need to understand the relationship so we know it's not necessary. So that shouldn't be too hard to find. And I think I bet there's a document out there.
So we have a close relationship with the community health centers through Ann Alley and our chronic disease. So we at the State Department of Health are intimately engaged with them. So we
Yeah.
can get more information about them.
Yeah, we just need to have a picture of what
Yeah,
they are,
mapping.
who they are, where they are, and what is the budget in each unit.
So just really quickly, in Indiana, we have federally qualified health centers. Those are the organizations that are receiving all of this federal funding. Those are the organizations that have strong lobbying power
Right,
in DC.
right.
Separately, we have state-funded community health centers. So
That's
when
who
we
I'm
look
thinking
at our budget of that allocation for state dollars, that goes to state-funded community health centers.
Right.
They are not federally qualified. So you can access publicly the full budgets of all of the FQHCs. That is public domain information, including all of their clinical sites across the state of Indiana. So all of that is publicly accessible, very well available. We can see how much federal funding they have. We do know where our state funded CHCs. I just wanted to make sure that you understood that our state health centers are not getting necessarily that huge amount of federal
that money.
funding. That's going to the federally qualified health
And
centers.
I wondered if that money represents some of the COVID money, because they got a huge
Yes.
amount of money during COVID, the
Yeah.
FQHC.
So
This
Dr.
is
Halverson, and then I think Shane, we
And
need
it's going to
to
federally.
finish
qualified
Shane's
health
presentation.
Yeah, I was just going to respond to Congressman Brooks's question, which is this does not represent the federal share to all federally qualified health centers at all. I mean, this is just a very small portion that actually probably goes to the state
Yes.
funding for community health centers. So, because you're exactly right. It's a huge number and does not reflect that number.
Thank
So
you.
Shane, back to Shane's presentation.
So real quick though, back on chart 11, then, Senator or Representative Brooks mentioned. So and when it says community health centers, is that both federally qualified community health centers or just the state?
Just the state.
Just the
It's
state.
just state, so it's
Because they
not,
get their money direct.
yeah.
We have nothing to do with the funding of
Right.
FQHCs. In fact, when you say community health centers, and you said that number, I was like, oh my God, our health centers don't get that kind of money.
Okay,
The FQHCs do.
But our
Okay.
Medicaid program does pay specific rates to FQHCs. So we are funding them as a state,
Essentially,
just
you're
to
right.
make
Through the
sure
Medicaid.
everyone's aware.
okay.
Yeah, through Medicare.
So that somehow that needs to be broken out, or
Yes.
we need to see that separately some way if we can. That would be helpful.
The budget of the FQHCs for the state?
Or however that can be broken out, because that's a big difference. Yeah. Sorry to interrupt.
No,
Thank you.
no problem. Okay.
So segueing back to local budgeting processes, I did want to note, while I said that many counties mentioned that they work well with their councils, in areas where we found that budgeting was, in areas where we found that process really did work out well, the common theme was the triad between the county auditor, the council, and the local health department, and they really were all working together on the same page. The auditor was regularly providing reports to the local health department as well as the council in terms of where resources are so that they can strategically plan. And the local health department was regularly working with the council as well as the auditor so that they understood what the strategic priorities of the health department were for long-term planning purposes. I think though, where this kind of dovetails nicely with the previous presentation that we had last commission meeting is continuing to reaffirm that need for finance and budget skills within this workforce, and noting that, you know, we really just kind of have a deficit of that in some of our local health departments, and sometimes even within a lack of understanding on the auditor or the council side of what goes on within the local health department. So really all around being able to bridge that knowledge gap. And in full transparency, local health departments express concerns with the myriad reporting requirements that the state health department places on them through the grants that we issue, as well as the templates that are sometimes unique to specific programs and have different data definitions or requirements. And so they felt that that was burdensome and sometimes led to frustration and consternation without, you know, really understanding some of the usefulness of the data being collected. As I promised, touching on Medicaid, Indiana, I'm glad to say some of our local health departments do this really well in terms of billing Medicaid for services that they provide. But as this slide notes, only 46 local health departments actually submitted a claim within this 1-year period for a total of $1.24 million being paid out during that time. The reason this is significant is it really represents money that's being left on the table. And so for Indiana, the aggregate number of support from the federal government for Medicaid claims is essentially 67 cents of every dollar of a Medicaid claim is paid by the federal government. So this is one area that if we were able to work with local health departments to increase billings, that wouldn't necessarily have a significant impact or as much of an impact on the state budget itself. What we heard from local health departments is that, you know, they're not really regular billers of commercial carriers as well as Medicaid in some cases. And so they oftentimes don't have that expertise at the local level to do so. What we heard from some folks as well is that when they do build up that expertise, that individual becomes a bit of a hot commodity and gets poached to hospital systems or other provider systems in the area where having that you know, public health expertise kind of pays dividends for them. So we wanted to just note that, again, back to that other slide that showed nationally 10% of local health departments' revenue across the country is from Medicaid. We definitely don't see that in Indiana.
Shane, could I add, one of the issues that it's important to understand is that there might be some sort of misconception that somehow we're leaving a lot of money on the table, which is true. However, the vast majority of what public health departments should be doing are non-clinical services. And that's really an important consideration, because there's a common misunderstanding that, you know, health departments simply provide health care services to poor people, which is not true. That's not what the function is. And so while there are a lot of clinical services that can be provided, and having been a state health officer in a southern state, I will tell you that some of our southern states get anywhere from 20 to 40% of their overall revenue from clinical services. Like, for example, in Arkansas, 2/3 of all the immunizations to children came from the local health department. So that's a huge thing. And the vast majority of the health departments in Arkansas, Alabama, Mississippi, Tennessee, so forth, actually do family planning services, a substantial amount of family planning. So there are a number of things that could be done. However, I would also say it's important to realize that nationally, and this has been the subject of a number of national commissions, the whole idea for public health is to increasingly get out of the clinical care services and to really focus not on providing medical services, but actually the non-medical population-based services. So while this is an important issue and we need to do a whole lot better job, and I think there are a lot of ways in which to make this more efficient, and I do believe that it's really important for the public health department to be that that guarantee the last resort provider, which is frequently been the case. And in fact, there's a lot of good studies that would suggest that public services that are provided at the health department are at or better than the quality of services that are provided in the private sector. That's not our primary purpose. And so it's just an important point to make when we look at the overall finance.
Thank you, Dean Halverson.
Just for a time check, it's 2:31, so.
Thank you. I'm going to just breeze through these so that we can continue the conversation. But I wanted to note case studies from 3 states that have been embarking on the very same thing that we're doing, and note that, you know, the motivations for their efforts are different, but that the process actually is not too dissimilar from what we're doing in terms of convening expert stakeholders and talking about these very topics. So Washington State's the first example, who have really kind of been an exemplar for implementing foundational public health services framework and candidly putting their money where their mouth is. So this is something that they've been working on since 1993, but more recently, after they were able to get past these boom and bust budget cycles, started injecting significant amount of resources into the state budget for public health. That began with an infusion of $12 million in one biennium, subsequently $20 million, and then more recently a whopping $146 million. And all of that really built around this idea of implementing foundational public health services. That initial pilot really focused on kind of creating some shared services areas and areas of focus within that foundational public health services framework. And so what they did is kind of injected money, created some reporting requirements around that, studied it, and then expanded upon that. And what I think is really interesting about what Washington State did in particular is they're also an early adopter of this Uniform Chart of Accounts project, which helps identify what the true cost of public health services are. And you can compare that apples to apples across jurisdictions, whether that is King County in Washington State or Marion County, Indianapolis. While those demographics may be very different, the way the Uniform Charts of Account project works is to account for those differences and create crosswalks between them. So I thought that was interesting to report on. Next, the Commonwealth of Kentucky's path down this process really was born out of their public pension crises. So what you see here on this chart is really over half of their local health departments had 24 months or less of solvency due to public pension obligations. And so what they ended up doing was similarly defining what the foundational public health services are for Kentucky and requiring counties to head down that path, but then codified a state funding formula that create a set number of minimum employees at the county level or the local health department level, and then recognizing that not every county is the same size, created expectations around how many employees per population were to be kind of that floor. Additionally, it also created funding formula for that, recognizing that we needed to also address the revenue side of it if we were asking local health departments to increase their footprint. They're still very much in the middle of that process, but I would expect their trajectory to mirror that of Washington State, assuming things continue forward. And then heading to the east of us, Ohio's been at this process for quite some time as well. This really was born more out of their association of county health commissioners. And Ohio, I think, began with something like 116 local health departments at the start of this process. And so what really was born out of this is ways that they could identify efficiencies. And I think, to be very candid, and I'm not advocating this for Indiana, but the goal with a lot of this work in Ohio was to reduce the number of health departments because there simply were so many. In fact, I think they have a number of municipal health departments that most recently, we'll talk about here in a second, are being asked to reevaluate what they're doing. In 2013, lawmakers enacted a bill in Ohio to require local health departments to undergo accreditation, also encouraging them to join with other jurisdictions. Now, again, what I want to reiterate here is that came with a certain amount of funding. So the Robert Wood Johnson Foundation actually provided technical assistance and funding to local health departments that were interested in undergoing that process. So they were able to kind of really do a feasibility analysis of what that might look like. And then subsequently, in this past session in 2021, a bill was adopted requiring smaller municipal health departments to assess their efficiency and consider merger. Lawmakers believe this is something that will help save money while still having county level services. But of course, the cities believe that that really does negatively impact their ability to make decisions at the local level. So gleaning or taking what we've gleaned and kind of aggregating it here on this semifinal slide, we wanted to provide you just some quick pro cons for each of the different models we've talked about. So the municipal corporation model, that's kind of akin to how Marion County is set up, really does provide flexibilities in terms of not having to always go before a county council for permission with respect to appropriations, but that may not necessarily be appropriate for smaller jurisdictions. Some jurisdictions are also not using their full tax levy, as we talked about earlier on. And so, maybe there needs to be discussion about what the minimum level of the floor of funding is for a local health department. On the other hand, we do know that many counties are at or near their maximum property tax levy, and therefore that's not really an option for them. So the only other way to bring that up is through local fees or taxes as well. And again, to Senator Kinley's point, in cash-strapped communities that may not necessarily reap the reward that we're hoping. I know that there's been conversation in the past about a state public health tax in terms of whether that's tobacco or some other excise type of tax. I think that's a conversation that's much bigger than this presentation, but we have noted that other states have used that revenue source as well, and just wanted to be transparent that, of course, this group has talked about that in the past. Similarly, perhaps over the longer term, having a more centralized funding model through something like the local health department accounts or the maintenance funds that the state kind of provides some per capita funding, but increased amounts might be a good way of providing some evenness to the funding across the state without necessarily attaching a whole bunch of strings, which is one of the challenges that we heard from locals as we were talking to them. And finally, having some bolus of funds from various related health settlements, such as the recent opioid settlement from the Sackler family, might help infuse cash at various points, especially since the opioid epidemic contributed to increased costs at the local level in a variety of ways. So as those are being negotiated at the state level, that might be something for consideration that we've heard in the past. So I will end here with this, and I know that some of you have seen this before. It was certainly a cartoon included in the Fairbanks report. This conversation is a tale as old as the public health profession, dating back at least to Dr. Hurdy, if not earlier. And Dr. Hurdy was the secretary of the Indiana Board of Health from 1896 to 1922. As a state, we pride ourselves in our being frugal stewards of the resources entrusted to us by taxpayers, and we've done well in that regard. But now we have an opportunity to invest in public health and as this question poses, focus on the fence, the safety, the prevention of injury, and making sure that folks are getting the services they need. A 2017 National Institutes of Health report found that the median return on investment for public health was 14.3 to 1. I think even by our shrewd Hoosier odds, those are pretty good. And so this is really an opportunity for us to look at that holistically and ask ourselves if we can do better. So with that, happy to answer any of your other questions you have.
Shane, thank you. That was very comprehensive and a lot of material to go through. So thank you. We have about 15 to 18 minutes or so for discussion now and further questions. And so Shane is open for questions. So,
A suggestion and one a question. I thought I knew a lot of the local functions and I've learned things over the years. And the other handout with the requirements that they're responsible for. I think getting that out to the local health department side, we had a conversation recently that there was something that came up and they didn't realize that that was a function they were, responsible for. So that may help with people asking for more funding if they realize, oh, here's a couple things we're not addressing. Is there an opportunity? My question is there an opportunity under the grant process for grants to go to say a district or a region rather than a county? Would that be a alternative to get funding to areas that perhaps the local government was didn't think they wanted to deal with that?
Yeah, I think that we could certainly look at that as a possibility. It really would take the local jurisdictions working together and establishing who that lead entity is. But from our perspective, I think we could look at that programmatically and ask ourselves, how could we make that work? I know for some of our preparedness funding, we do kind of take a more district level approach, but we might be able to look at that in other ways.
Thank you.
And we have done that when local health departments don't want to take it, we have funded other local organizations to meet the needs of whatever particular population or community we're trying to help.
I was just thinking of our previous discussions about regional approaches.
Some states have authorized like their public health institutes as well to be an intermediary and to serve then a function that would be for shared services and so forth. So there are many models that can be considered.
Shane, one of your slides showed how, or talked about how decentralized the delivery of public health is across the state. You also mentioned that the Department of Health's budget is $535 million. And you looked at how much budgeting dollars are applied at the local level across the state. So you can look at just the scale of delivery of public health.
Sure. So I want to clarify something that I realized now in my remarks I did not mention. On that slide in particular, yes, our current appropriation is $534 million. 161 million of that is COVID related funding. And so that presents itself as a cliff in a couple of years. So if you really look at our budget being closer to, let's say, 350 million for round numbers, of that, about 40% of that ends up getting granted out to locals in a lot of cases, but not always. So what we can do is kind of dive deeper and see how much of that actually gets.
Yeah, what I mean is if we're looking at how do we more effectively provide services across the state, and if you look at all the collective budgets in each of the 92 counties, for example, how many billions of dollars are we already kind of starting with when you're looking at how do you improve the delivery rather than it being decentralized? Because I know that part of what was discussed here was do you centralize or regionalize some of the delivery systems and what impact would that have to improve the outcomes? Can you do more if there's more focus rather than being decentralized the way we are?
Sure.
Dr.
Yes,
King?
Dr. King.
So I really feel that a lot of the local communities have a better pulse of what's going on in their communities. But because there are smaller health departments, they don't always have the level of expertise to carry out everything. But I think they could really be enhanced if, say, for example, we're already divided like in the 10 districts for like a public health preparedness. Local health departments might need an epidemiologist. I need someone to analyze my data, but I don't have those kind of resources to have a epidemiologist for my small health department. But if we hired a epidemiologists that could service 5 or 6 health departments, that one person that could help provide that data, that would really enhance the effectiveness of those smaller health departments. And so I think we need to consider thinking about identifying what are those positions that a lot of local health departments would really need, or they're pounding on the State Department of Health trying to do all 92 counties at one time. But if the state had a number of positions that some employees, based on whether it's informatics, epidemiology, it could be a number of things, environmental health, but it could be shared. So you're not having to have to do an entire building up an entire local health department, because that might cost a lot of money. But can we figure out a way how we can have some critical positions that are shared by 5 or 6 local health departments who, I want to be able to pick up the phone and call and access and do that. I think we could really be creative in terms of figuring out a model that could really enhance our local communities, but provide that expertise that we wouldn't have thought about.
On that note, I would ask as a follow-up question, Dr. Kane, is or Shane, are we planning any surveys to each of the local health departments to solicit that information as we really try to figure out how to improve the delivery
Yeah, so
with the resources that we have, or identify which resources we do need?
Yeah, we definitely are. So one of the things we're doing, especially after the conversation at our last meeting, is reevaluating how to make sure that local health department annual survey is really gleaning the right kind of data. And I think that'll be informed by this. And I know that Pam, as part of her governance presentation, is planning to survey local health departments as well for some
We're all
additional
trying to get
information.
accredited. We may need someone to, I can't pay for a person to just handle all the accreditation. But maybe there's someone that can help provide technical assistance, give me the basics, and I can get my people to pull the data together, but I don't have enough staff for someone to spearhead that and do that completely. So I think those kind of things, maybe.
In our, from the informatics and data analysis standpoint, we have done a large survey of all the local health departments. So we really are doing those key surveys. We don't get a very good response. I'll be very honest with you from that. We have a handful of local health departments that do that. And that's why we're trying to compact that down and say, like, this is really a critical one. Could you please answer these key questions in these key areas?
If they thought they were getting money, you might.
Yeah.
There's the
really
carrot or the
true.
stick approach.
Honestly, I don't know that money would make the difference on it.
They don't have time.
I would go to Mindy to say that they
Yeah,
just
we
don't
might
have
want to
the
solve
time.
that. Mindy and then Dr. Halverson.
I'm going to be quick, but a number of comments. Great presentation. You really hit the nail on the head with the grant issues, the pitfalls with just doing money via grants. It's really cart before the horse for us. So excellent job on that. Dr. Box is right. We are all so understaffed to do the core stuff that we need to do, that to think of having what would be ideal, a similar commission or coalition like this, or made up of some of these partners in local levels, so that you don't have repetitive things being done or initiatives where you're taking money would be great. It's ideal, but we're not set up for that now. And so beefing up public health as we need to do it, even for the core services, would help do that. Some are very skilled in gathering partners and talking about collaborative working environments, but some aren't, because they are just barely having one person to do everything within that office. So we're
Right.
just severely set up poorly. Two things I want to highlight. So one is on the funding side, any money that we do get from federal money that's passed through from the state, it's not discretionary at all. It's all prescribed. So the money that we get is all told to us for what like what project, what program, the actual duties, the things you have to do. There's nothing that says, hey, what does this region or this area need to do from a public health standpoint? Or what does your coalition regionally think is the priority in north or south? It's not like that. So that leads to disparities of not wanting to take certain monies because you already do that program in your area because you have proactive hospitals, for example. So those things need to be looked at when you look at that whole picture. And when you're thinking about those monies coming, those are prescribed monies. They aren't helping most of us in the ways where we are having the problems. And we have to be careful if we start talking about the change in any of the clinical services that some of us do provide, because that'll create the burden that then the medical folks would have to provide that. So nobody does the backside of STDs but health departments. So you don't do the follow-up, you don't do finding the partners, you don't do any of that.
Yeah.
And if you punt the clinical side, you'll lose the investigative side. So we need to think full picture, like really, really thoughtful things if you're going to think of changing how you service delivery, some of the clinical stuff. The other thing I just want to say is that the things that we don't want to do also is create any barriers for people wanting to seek treatment for some of these diseases that have stigma to them. So not just opioid stuff, which is still a hard thing to try and deliver services because it's governed by elected officials who sometimes don't want that. So that is difficult. But the other side of the STDs and TB, when those happen, a lot of people don't want to seek services unless it is to a local health department who also does the full care and it's free. So you can't, if you're uninsured and all those things, a lot of that won't happen. They won't go. And then you'll just have disease spread on like syphilis and like the opioid stuff that led to HIV. So those are just my cautions, very quickly said. Nice presentation. Thank you for listening.
Very good. Very good. Dr. Halverson.
I was just going to reiterate, and thank you, Mindy, for your comments. In particular, I just want to emphasize the importance of some of the clinical services that are provided are just crucial. And I don't want my comments to be inferred to suggest that we ought not to be doing clinical service. I'm just suggesting that nationally, this issue around clinical services has been an often debated issue. And I think it's a matter of trying to find the right balance. And as Mindy and others have said, I think a lot of this comes down to what's available in the community. And there are some things, however, that I think should be definitely provided by the health department regardless, and STDs and TB and other things like that I think are critical to have the capacity within the local community to do within the health department. But beyond that, the issue of doing a survey. So this strikes pretty close to home in terms of we do a lot of surveys, but part of the issue is in order to do a survey that's meaningful, particularly around trying to ask people, so what would you like help with, or what do you want to do more of, and so forth. Those are all good and well, but I would just suggest that, again, based upon my comments from last meeting, we have not yet determined what it is that we want to be done in public health in the state. And so it's important that we recognize that when we do a survey, we need to sort of recognize where we're at in the maturation process of this work. And so I think when we do a survey, we should do it at a time when the results will actually inform the process. And since we have yet to understand exactly what it is that we're going to ask local and state health department to do, because I would at least suggest that it needs to be substantially more than what we're currently doing. We need to just be really careful about when we ask and how we ask. And Dr. Box is right, because I've been doing a lot of surveys in Indiana since I've been here, and it is almost impossible to get good survey results or participation level. I mean, there are people that'll show up to a conversation, but most of those people won't fill out a survey. So, and by the way, that's not just unique to Indiana. In public health, it's a really hard. So.
I have a quick question to our county officials. Are there other services that the county provides that you share with other counties? I mean, I was trying to think in public safety.
Just public safety.
But just the shared agreements, the mutual aid agreements. But when you have the mutual aid agreements with law enforcement, police and fire, do you actually share personnel? I mean, they come, I don't understand those well enough, and I should, having been involved in public safety, but financially, if they come and help you, are there any shared expertise like Dr. Kane's talking about, that you share in other areas? Economic development, public safety.
I do mosquito control,
Public
so,
development, economic would be, it would be regional again.
See, they do with economic development. You have regional people that you share.
Same thing with
Right.
Public safety, it's regional in our districts for Homeland Security.
Okay. And do the counties contribute portions of that person's salary or something? Is that divvied up?
Initially, when we set it up at the beginning with the districts, we got a grant for a administrator for each region, and that administrator was paid to coordinate, to interact, to help develop that camaraderie that keeps the regions going.
Okay.
Do we have some-
And, you know, I would just echo what Mark said, that most of the sharing within the county is not necessarily sharing cross-county
I wonder.
lines, but it's sharing within the county with towns or cities where the county is providing services to a town or a city, or vice versa. And,
Mhm.
you know, really, it's just providing those services. There's no real sharing of dollars going back and forth.
but you know, if you were able to buy things, you have all these counties and they're buying things, you know, you could get a huge discount,
Buying power.
figuring out, you know, who's the primary person, so,
Right.
you know, that would be huge. We do mosquito control. We share that with counties. When we had some outbreaks of lead poisoning, we share our staff with the other counties.
Yep.
So they can use our staff. We never charge them or anything. It's just, you know, we're being a good neighbor.
Mhm. Okay, thank you.
We do
So
charge mosquito
last,
control.
last comment, Dr. Bill.
And it's more of a point of clarification, Senator Kinley, on what you said. So today, the way that some of the funding works for public health or for local health departments is it's based off property values, correct?
Yes.
Yes.
Okay, so
Yes.
it feels a little bit like I don't know how else to, I mean, off the top of my head, we're making the rich richer. When we look at property values in the areas that are of lowest value, we're not doing anything to make it better
Right.
by funding this. It's just going to continue to get worse. So our funding can potentially continue to remain poor.
Right. Well,
I guess maybe that is that method the best method to,
yeah.
and I know Shane mentioned that in his presentation.
The thought that I had that was beyond the discussion that we had here was to when we revised the school funding formula, it used to be that schools were funded quite a bit by property taxes. And the locals funded a share and the state funded a share. And so the state took over 100% of the funding for school operating. And when we took over the funding, then that allowed for us to develop a school funding formula, which distributed funds to everywhere based on an equitable basis. And the formula that we use is based on the demographic characteristics of the different zip codes. For example, you had a greater need in, of course, down here in Indianapolis. And then out in the rural areas, you had the same kind of like Spring Valley down in French Lick, you know. Their poverty level was just as high as its inner city of Indianapolis. So we threw the funding out on a state basis based on that characteristic, as opposed to arguing about who should get it on a political basis. And, but we raised it all at the state level, and that's why the state took over 100% of the school operating funding, so that we could then do that. And so the thought that was going through my mind as I kind of walked through the first half of that discussion was, I wonder if we could do a similar thing in terms of if the state commits to raise more funds for healthcare, if we could do a levy by the state and then a distribution on a formulaic basis like we did with the school funding formula.
Very good. So we have come to the top of the hour. Did you have one last burning?
I do think there's merit in what was discussed about having these centralized important positions that if,
Yeah.
you know, there's always going to be some sort of brick and mortar public health in each county, but we don't have any trainers. And so
Right.
some of those things could be very good ideas. Epidemiologists are really good. I think we need to make sure that's in the minutes to discuss. at a
Well,
later
and
time.
billing as well. I mean, the Medicaid question, there's technology. You can have somebody sitting in one place taking care of all
Right.
that. So there's a lot a lot of great ideas that have come up today, and more to come. We have a lot of work ahead of us, but I want to thank everybody for your engagement today.
Dr. Monroe,
Again,
she got to speak. She wanted
If
to
you
say
can
something.
just indulge me, I just wanted to make sure everyone is aware that this coming Monday is Public Health Thank You Day,
Oh.
a national day, international day. And obviously, our public health workforce has had more attention on them than ever the last few years, working tirelessly, but also under tremendously difficult circumstances. And so words feel very inadequate to say thank you, but I wanted to just take this moment to say thank you to our public health workforce, and also just hope that we can all come together to put some things into action that will demonstrate that gratitude in future years. So thank
Yeah,
you.
well said. That is this Monday. Thank you. Thank you. And our next meeting of the commission will be Thursday, December 16th, same time and location. The topic will be governance, infrastructure, and services. So that'll be a good carry forward from where we are now. And with that, meeting's adjourned.